We can hear you a little more, Jesse.
Okay. How about
We
the
can hear
boom?
you, Silva. And this. We can hear you, but we're still having some folks come in, so, we're good.
Okay. Well, we'll start then with the introductions here in Asheville. Well, I'm Jesse Smathers. I'm the Innovations Technical Director at Smoky. I'm in Asheville instead of Silva. I'm geologically or geographically challenged and couldn't make it to Silva tonight. So maybe in January, if it doesn't snow. We'll start over here across from me. Yeah.
I'm James Quay, our uncle in the city of support services.
Ray?
Yeah.
Aaron?
No, a little bit.
Eric, okay, sorry. Chris, okay. Who? Carolina?
I'm Jane Lindsay.
And Lynn English.
Now I'm Wanda Steele, I'm a provider.
Our story?
Elaine Summersgill.
Annette Cooper. I'm Caitlin Stills.
Kathy Rader, Aaron.
Janet Price Farrell, a parent and executive director of First. Sherry Brackett, parent.
Okay, we'll move to Silva next.
No, that did. Can you hear us?
Okay, can you hear us now, Jesse?
Yes, we can hear you.
Okay, great. Jody Miller, Family Support Network.
Beverly Gaddis with Macon Citizen Ability.
Kelly Kelly, University Participant Program at Western. Paige Everly, Easter Stills. Julie McClure, Family Partner with Smoky Mountain.
Robin Van Wyk, IDD Clinical Director, Smoky.
Okay, let's move next to Lenore.
Tommy Abel, Skill Creations.
Mary Short and my daughter Katie, parent.
I'm John Fraser. I'm the IDD Care Coordination Manager for the Central Region, Smoky.
Is that everyone in Lenore?
It is.
Let's move on into Boone.
Christy Lupton with High Opportunity.
Megan McLaughlin, parent.
Roger Giles, Home Care Management Corporation. Monty Ryan, provider.
Ray Roman for RHA. Christy Pruitt, IDD Care Coordination Director for Smoky.
My name is Michael Manifest McCoy for the Stakeholder Committee.
James Duffy, Turning Point Services.
Howard Richardson.
And Tina Clark.
One more arrival here in Asheville.
Michelle Jones.
Okay, thanks. Okay, I guess we have more people than I thought. It's hard to tell sometimes on video. Oh, the agenda, I have the agenda broadcast. I'm hoping that everyone can see it. We've already done the introductions. And if you'd please take a look at this agenda, is there anything folks would like to add to this agenda? I'll start first by asking persons in Asheville, anything that you'd like to add? Going once.
Where is the agenda?
Oh, it's the very front page of your packet, it should be. And I've also had it posted up here.
Are we gonna have suggestions?
There will be suggestions touching on waiver development. Yeah, that's part of the state level stakeholders meetings and the policy development. Okay. Anything, I'll go to Boone next. Anything that y'all would like to have added?
I think some shaking of the head saying no, so I don't think so.
All right. We'll move then on to Lenore.
No, it's fine.
Nothing here.
Okay. Okay, easy crowd tonight. Let's move on to Silva.
Nothing.
Okay. Can I get a motion to approve the minutes? Or I'm sorry, the agenda. We aren't to the minutes yet. All right. And the agenda is approved as written. All right. Now let's move on to the notes. That should be the second part of your packet. Okay. As folks look over this, I'll review the action items. The first item indicated in the minutes was a discussion about the creation of the committee. And the action item was for letters to go out by November 15th. We did not meet that deadline. We were about 5 days late, but the letters have gone out, which we'll talk more about that once we get to that item on the agenda.
Yeah.
And in the email that went out with the letters, there should have been the final draft of the charter. I have that here too to discuss. And Julie took care of sending that application to the additional interested family. Oh shoot. I emailed out the site information about different places to post information. That was in the email that went out, I think it was the 19th. I was a few days late because we picked a day that fell on a Saturday. That's what I thought. I received a lot of feedback regarding the definitions, which we'll be talking more about that later. Julie McClure had a group, coordinated the meeting of a group in Silva, and they provided a lot of feedback, but I was really overwhelmed by the amount of feedback that I received about the definitions. And I received quite a bit of feedback regarding, went to the very spot down. I received quite a bit of feedback about the relative as direct support employee, and I have reviewed that information internally at Smoky, and I have some information to discuss about that near the end of the meeting. Can we approve the meeting or the minutes as written? Is there anything missing that anyone recalls?
So moved.
So moved? Okay. So these will be marked as approved, and they'll be posted on our website as soon as we get that link developed. So I bet you the one thing I didn't move over for broadcast was the charter. So it's the document in your handout. It looks like this. It says Innovation Stakeholders Committee Charter. And I will point you first, as we review this, to the membership part. Our ultimate goal was to get 6 members from all of our 4 regions. We did not accomplish that because we did not have enough interest in certain regions as far as applications. We received 29 applications, and a lot of them were from the Western Highlands Legacy area. We had a total of 4 from the Western region, which is the Silva group. We had 6 in the Northern office in Boone, and 3 in the Central area. Actually, I made a mistake. I moved 1 family member into the Central region, and with the selection, we've ended up with 18 family members and 6 providers. But the breakup is not as we had hoped with the 6 members from each region. On the next meeting minutes that go out, there will be a list of all the members. I have it right here. It's just not posted yet. Letters from Brian Ingram went to everyone that was selected, and folks were selected blind random draw with numbers in a hat through them out. So that was the selection. And we have 2 CFAC members, and a few folks have notified me that received the letters that they couldn't attend today because of the holidays and they're in other places. So we actually do have a formed committee. I know that several folks here today are on the committee. And future meetings, that will be our voting body. Because we really do not have anything to vote on today, except possibly the relative as direct support employee once we cover that information. Are there any questions about the charter? Let's see. First, let's go into Boone. What's the question?
This is Roger, just clarification on membership. Is the meeting still an open meeting, just the membership of the voting members? Is that how it works?
Yes, Roger. The meeting will always be open, but when we do votes on anything, if we have to do votes, it will just be the voting membership. I don't foresee us having to do a lot of votes. Any other questions in Boone? Okay. Any questions we had one question in Asheville, Kathy.
I don't see on the charter document that it clearly answers the question how the committee informs the MCO.
Yes, and I can explain that. And this is what I can do at the next meeting to make that more clear, is bring an internal organization chart or committee. Because I added all the places that the Innovations Committee reports within smoking, and I was informed that I shouldn't add those because it needs to be just around the pieces. This committee goes straight to the Innovations Committee. The Innovations Committee reports to every committee within smoking. And that's demonstrated on our internal CFD chart. And you will see that feedback from this committee regarding relative as direct support employee that we talked about last month made changes to that communication document. So once we get to that, you'll see how that happened, and I'll explain the process of where all I had to take that document and the feedback, because I've been in more meetings than I can count. Mind you, I can't count past 5 really, but I've been in lots of meetings about that document with different folks, and that all started with this committee. Then, actually, we created the Innovations Committee. We took it to this group, and we stepped back after y'all's feedback and made some other changes, and I actually discussed that for some finalization with our management team on last Wednesday. And that's why we have a document that's informed for this group. I mean, not all the pieces will make folks happy, but there are changes in it that will make some people happy.
Changes in which document?
The communication about relative as direct support employee.
Oh, okay.
So that's one way I can explain that piece.
Okay.
And I think that, Robin, would you make comment in the notes to have me bring the committee structure to the next meeting? Okay. Yes, Jane?
Couple questions as we're doing this. Are we going to have subcommittees out of this one committee? Are we going to be able to break away into, a lot of discussion was made at the last meeting we were at about repercussions and people being intimidated and afraid to speak up because of fear of repercussions. You know, and one of the things I thought about, could questions or concerns or ideas be sent in writing, be presented that would be anonymous? And can we break into subcommittees of families and providers? Because many families are afraid to speak up. Kathy's shaking her head because she probably talks with a lot of families.
I don't think they're scared as much as they don't know how to.
I think there's a lot of fear. What do you think, Price? You listened to it last time we were in.
Well, it certainly sounded like some families were concerned about that, but I know providers are also concerned.
Exactly. Exactly.
But what are they concerned about?
Retribution.
That if a parent says something that is negative about a provider, then a provider would.
Pull out or give notice. Yeah, just a fear of repercussions, and I guess there's also a fear of repercussions on the provider's idea from smoking. That if something occurs, we may look at that provider differently. It's a small world, and it's dominated by fear.
Or unknowns.
Or unknowns, right? So I got your email regarding that, and I'm waiting for some feedback too from internally. This group's already put together one small group with regard to reviewing the service definitions. I am not sure what the answer would be. I know that there will be times where we'll have to create smaller work groups, I think, to take a look at things.
And another question, we had discussed at previous meetings about the number of individuals on the committee. And from my experience, and probably others in here that have been on committees, they start off with a lot of attendance. And then if it doesn't turn out to be what they thought it was, or time goes by, the attendance seems to wane a lot.
Yeah, I guess, is there anything in here, and I missed it if there was, is this an annual appointment?
Yes.
Okay. So annually, if somebody ended up not coming and not participating, then.
And I think that we definitely could probably, because we had 4 other folks that were interested that weren't selected, we could add them as alternates, because I know some of them come.
That would be a good idea.
So alternates, and since our group number's 24, we really just have to have 13 for a quorum. So as long as 13 voting members are here, we could vote about something. And we have 13 voting members here based on the folks that were included. So
I think if people know who's on the committee and are able to contact them, email, some way, to say, here's my concern, that it's not to. And if you're not able to come to a committee, then you should speak up.
For other families.
For other families and for yourself, with, whatever happens, but I won't let anybody intimidate me, whether it's with you or Medicare or anybody, I'm not telling you what to think.
mm-hmm.
But I see that also in my own life, in the HOA, I mean, everybody can tell you. So, but, if we're gonna be on it, then it should be there, it should be open that we can get that information. So you go.
with our wait list identifying the members that, for each region. It would help with that. Or not with our wait list, with our website.
For those here.
But then the person on the committee doesn't know how to say things without disclosing where they got the information. Because usually the committee members have connections, so it can come from all kinds of places.
Okay.
The committee members ought to sign confidentiality.
Confidentiality, okay.
Yes. So that somebody can tell them something, they're not going to disclose that information.
Okay,
The self-identifying information.
okay. I think we have some questions that Silver caught. Rob, anything, Silver?
Well, first I need to just, if we can stop for a second and summarize where we are so I can make sure I'm getting notes on all of it. Because all I have is for the action items, you want to add the 4 people who sent applications as alternatives. The committee members need to sign confidentiality forms. What else did you guys talk about? I'm sorry. Hey Jesse, can you hear us?
I'm sorry. I was looking at red lights and talking.
Thank you.
But the other was to identify the members on the website when we start posting everything,
Thank you.
which that should be coming. By our next meeting, we should have a link that's to our website, since we do not meet again until January. So, and I think that's all we really had. Any other thoughts from Silva or Lenore?
Yeah, Jesse, this is Walter. I know when I'm on a state committee, I have to do an ethics training every year, where we actually have, there's a training that we have to go through and all that kind of thing. Or is this stakeholders group going to have any kind of ethics? Because they talk quite a bit about conflict of interest and what you can and cannot talk about, what you can and cannot do, and those kind of things.
That's a very good question, and I'll have to take that back, because I do not know if it's done with our CFAC group.
No.
Is it done with our CFAC group?
No.
Last I heard, CFAX didn't have to do that, and that's kind of odd because the state has a huge ethics training that they require state people on state committees to go to. And they talk quite extensively about what you can and cannot do and what your rights are as a committee member.
Okay.
We don't do it as client rights either.
What committee do you sit on at the state level, Walter?
I used to
I
serve
can't remember.
on the DD council, but
Okay.
has asked me to step down from that, so I'm no longer. But any committee that is state appointed by the governor requires that ethics training. And if you go to the North Carolina Ethics Commission, you can see all of the stuff.
Okay. I'll take that back internally to Smokey and get a response for the next meeting. Okay. Moving, was there anything in Lenore?
Anybody have anything?
No.
Apparently not, I think we're good.
Okay. So,
Just so y'all know.
from the beginning, the last time we met, I talked to you about the 3 definitions that everyone's looking at the state stakeholders meeting. And this whole process as it evolves gets more and more interesting. So right now we have a state stakeholder group. Membership on that was sought by the divisions of medical assistance and the division of mental health, developmental disabilities, and substance abuse services. And that committee is chaired by Dave Richard. And they are meeting every other Friday to get stakeholder feedback regarding development of the innovations waiver, or whatever it ends up being called. And the goal is to have this waiver ready to implement by January 1 of 2016. For it to be ready to implement by that date, it has to be submitted to CMS, the Centers for Medicare and Medicaid Services, by spring, because of the back and forth that happens between agencies. Well, we had started looking at the definitions, and some of the definitions, integrated support, supported living, they were taken to the stakeholders group in Raleigh, and the stakeholders group in Raleigh wasn't very happy with the definitions. Those were shared then with our stakeholders group, and I started getting feedback from y'all, and there was a lot of concern voiced about how the timelines weren't sufficient, because the deadline I gave you for those 3 definitions was November 5th. Well, you guys, as a local stakeholder group, were not the only ones to complain about those timelines, because each MCO, or managed care organization, has a local stakeholders group that they're communicating this information with. And the other local stakeholder groups complained about the timelines. That was heard at the state level, and we took another step back and developed this overview of the waiver as it currently is, breaking the service categories into different groups, and coordinated a timeline to where the first group of services will be open for feedback until December 19th. So if you haven't had an opportunity to give us the feedback, you will have. And we've simplified the format for getting this feedback, and that's what I'm going to share with you today. I guess I've been going over the first slide, which is the outline of the process, but by stepping back, we'll be taking draft definitions to the stakeholders group. After this presentation, they're expected to give us some feedback. We'll be presenting that to local stakeholders and gathering more feedback, incorporating that feedback, and then taking the final draft to the state stakeholders group, which meets every other week in Raleigh, and they'll have the final yay or nay on the service definition. So
you're doing these services in groups. This was the first group.
Well, we've extended the timeline on the first group, which I'll get into here shortly. And this PowerPoint that I'm sharing with you, Jamie Markham and I actually presented it in Raleigh on Friday. So we're involved with the state stakeholders group too. And just to touch on the goals of the waiver, because we overlook these sometimes, and these are things that we can't really remove from the document, not that we would want to. But the goals of our waiver are to value and support participants, to become fully functioning members of their community, promote promising practices, offer service options that gives the person maximum choice and employment, some type of day activity that's meaningful to them, opportunities to participate and to direct their services if they choose to, increased educational opportunities, maintain health and safety, maximize self-advocacy, increase opportunities for community integration. They get a little redundant, don't they? Deliver person-centered services that leverages natural community supports, and then provide quality services and improve outcomes. One thing we will be talking about a lot more is improving outcomes as we move forward. The service definitions are supposed to be tools that we use to reach those goals that I just reviewed. And we're going to touch on each of the definitions tonight, and we've really simplified it into, we're going to ask you, when you're looking at each definition, what works, what doesn't work, and what's missing. Like I know some of the feedback that I've received from our group before, they're setting the alarm bells. You're going on. We won't be able to escape the building now. I'll have to set off the alarm when we leave, but, so we'll be asking you what works. Like there's parts of residential supports that really works. It's a 24-hour service. That works for most folks. We often hear that it's not working, that there's no respite for AFLs. So that would be an example of what doesn't work. A lack of medical training in some cases could be an example of what doesn't work. And then what's missing? What categories of need aren't covered by our service definitions now? Those are the three questions you'll be asked when you are looking at definitions. And what's changing is our waiver. We're going to be trying to change it to where it gathers all the possible needs and gives us the tools that folks need to reach their outcomes. And we've broken our categories, our services into categories. So the ones that we have are, well, first we created the category living, and that simply is choose where I live, because that's the goals that these service definitions tie to. In-home skill building, residential supports, community transition, respite. Also included in that supported living and integrated supports, which we touched on. But none of those, we're just showing the existing services right now. Crisis supports, the goal of that is to keep people safe in their community. Day activities, or the day category, is how to spend my day. Right now we have day supports and support employment. Community, choosing what I do in my community, and that can be through community networking, community guides, supposed to help a person navigate and find activities. The waiver is expected to offer persons the opportunity to manage their services, and the two services we have now for that are individual goods and services and financial support services. There's education opportunities in the waiver, natural supports education and specialized consultation. And then of course the waiver also has a set of equipment. The adaptive supports person's needs, and this is assistive technology, home modifications, and vehicle modifications. On the choose where I live category, we currently have in-home skill building, personal care, and in-home intensive supports. Respite really falls in this category too, because it supports persons in their home. And what we're talking about doing, and you all have provided some feedback about, is combining these three services into one service definition. The proposed name is integrated supports. And the idea of that is for it to mirror the natural flow of a person's day. I know folks have said that they're not really happy with that name. Some folks do not like the idea of blending the three services, whereas others do. But those are some of the things that you'll have the opportunity to provide more feedback on. Because this category of services, choose where I live, it's in the category of services that will need feedback by 12/19. And the email that I'll get out to you all before Thanksgiving will explain this in more detail. Residential supports is a service that we use for choose where I live. It teaches skills, assistance, and everything occurs in a provider-owned home. How does that need to be changed? That's going to be based on feedback. I've already mentioned the AFL needing respite. There's probably some other things too. Community transition is a service that falls in the choose where I live category. And this service allows persons to move from a provider-operated home into their own home. So we can use this service to help a person purchase certain furniture necessities, to pay deposits, all sorts of things for a person to have their own apartment, as long as the person's moving out of a provider-operated home. And then respite is a relief for primary caregivers. Some of the feedback that occurred at the state level was that we needed to add more clarity to the respite definition so that it didn't appear to be just babysitting. so that a person could be taken into the community. Make it more clear that if a person's receiving respite, they can go to a movie or do activities in the community, because evidently there's the perception that those things can't happen with respite among some providers. I know that's not an accurate perception. That was shared in the stakeholders group. And then supported living's been proposed. We don't currently have this service. And this service is going to be a daily service that's provided for a person that's living in their own home. And we're differentiating in this manner from family home and provider operated home. This would be the participant actually renting their own home or owning their own home.
It's on the lease.
Right. Exactly. That's exactly how it's put. Folks would, this is a better practice in the field because persons would, their name would be on the lease. If there were problems with the provider, instead of the person having to move out of the home, we would be finding a new provider to come into the home. That's the big difference. And there's also some benefits because legislation allows for up to 3 adults with disabilities to lease their own home without it requiring licensure. So 3 folks that know one another could choose to rent a 3-bedroom home, and with this service we can work out ways to staff that home so that they could stay there no matter what happened with providers. Because what happens sometimes in our residential placement settings is that a person has a behavioral crisis. It becomes very challenging. The provider, it really just can't handle it anymore, so they give us notice and we're looking for the person a new place to live. In this circumstance, staff would be rotating. It would be the person's home, so when the staff's burn out, we're finding someone else to come into the home instead of having to uproot the person and move them into someone else's home.
But you still have the same problem if you got 2 to 3 people in the home. I own it, and you're in there giving me grief, I kick you out.
Not if you're all on the lease.
But it's one person on the lease, was it 3?
Well, in the circumstances we're talking about, if there's 3 people, it would be 3 people on the lease. And if they couldn't get along, everyone would have tenancy rights. It's moving towards the idea of if you're renting a piece of property, you have to have the rights of citizenship and you have to be evicted and all those pieces. And if the 3 can't get along, then one would have to choose to move out.
But if I own my home and I choose to get a body to live there, you're still in that same spot.
Yeah, but if you own it and you're leasing a room to me, you have to give me the landlord-tenant rights. So there would have to be signed lease agreements.
There's going to be a lot of legal stuff.
But the families are intimidated now. I gotta make my person behave. I gotta let you drug them so they can stay there.
Yeah, but it's not going to be a provider-operated home. So that's a difference. You may just, in some cases, have one person living by themselves. But if you do have the 3-person scenario, you definitely want 3 separate rooms. Each person would have their own day activities. And the monitoring that occurs at nights where the blend is.
There'll be some legal help there. I mean, we have to find out home.
Yeah.
One of the 23 counties, the one person owns it.
Yeah.
The other people don't have a lease agreement.
I know, that's because currently it's a provider-operated situation.
So there'll have to be some way to bring in a way to help y'all out.
Yes.
Leases, so is that going to be somehow covered? Do we pay for it?
Well, he's not we all have 3.
No, I'm just saying, no, but I guess that's one of those.
That circumstance you're describing is one of those things that we could address more easily under this manner because the people in that home have guardians and the guardians could work out the lease agreement. So we right now, that's being operated as a provider home even though it is owned by a tenant because of past things. So there's a lot that this will fix, or this definition will help address it.
If you have multiple leases,
yeah.
multiple people in a home.
Well, we need to get away from this topic because this is a very specific.
Okay, Rob,
Yes.
thank you, because I'm not taking notes. I thought that, because this is under choose where I live, so the feedback's not due till 12/19, right?
Right.
Or is this the feedback right now?
No,
Both.
no.
Clarification.
This is just
Thank
clarification and answering questions. Okay.
Yeah.
So,
Can I ask just one
That's
thing?
it, we have a question, Dave.
okay, question in Boone, then we'll come back to Asheville. Yes.
If the three people were on a lease, would they all have to have the same provider?
No. That's what's supposed to be separate from it.
Yours was just an example.
Yeah, like, this is supposed to be, yeah, it's the home's the person's home.
If they're sharing staff, how will they not have the same provider?
That's a good question to take back to the group.
That's why I think this is one of those definitions that have a lot of discussion around. Because it's a lot, it's a nice idea, but how you implement it.
Well, and you see in some of,
This is great, but 2 or 3.
some of the circumstance is the idea that there may not even be a staff overnight. There would be a staff that's within early response. And we're not talking about folks with severe and profound living in these circumstances. This is a service where folks that sleep overnight, get along. There would be monitors and some assistive technology in the home, because all of those things can be put into the apartment setting if it's owned by, or if it's leased by the tenants. And there's a lot of detail that has to be worked out with this.
It does call for one level of weight overnight staff in there, so it's an interesting definition.
It is an interesting definition.
That, as we start talking through.
Although it's a great opportunity for creativity.
Yeah.
And that's, like all those interesting comments, that's where you can send us the feedback. All right?
My question, Jesse, is are there safety practices being put in place for a service definition like that if providers are lost? If no one is there to go in and help these individuals? There needs to be some kind of safety or something built in that there's always going to be someone there to help them.
Yeah, and then the way that works in certain settings now is that the staff that's there doesn't leave until the relief staff is found.
What if they walk out and quit?
That's where you need a QP to come in. So that, there's definitely challenges about it. But it's the whole goal is to create the opportunity for persons to live in their own apartments.
And I think there's a lot of challenges ahead of that one.
And there's lots of challenges, but they're pulling it off in Wisconsin pretty successfully, using a lot of technology. And what I see, it's a philosophy. There's some philosophy change too, because and it's tied to the idea of dignity of risk. Like a person with a mild intellectual disability has the same rights to experiment life that a person without. Typical person, exactly. But one thing our system has done in many ways is wrap around monitoring to the point to where they really can't breathe without someone watching them. And it is a complete philosophy shift in the idea that we're not here to protect the person as much as we are here to give them the opportunity and support they need to make their choices and live their life. And it's a different way of thinking. Yes.
Well, and as a parent, our whole wish is for them to be able to reside in their home after we're gone. I think that's a wonderful opportunity.
Yeah, it's going to be a little different than it was previously because of the idea of moving away from provider owned and provider operated. So Let's see, any other comments on this definition and any of the other locations? Because I need to get moving, being mindful of time. I got a feeling I'm going to get a lot of feedback on this one.
I was just saying, if that's what I pursue it really,
Yeah.
because you've got like technology that would allow you to, provide for their safety, and on one location where one person might be looking over 5 or 6, apartments, like an AED type thing. So, it's really worth pursuing. I think it's a wonderful idea.
Okay. And that category, choose where I live, I'll have to have feedback on it by December 19th. And as I've said, I'll be getting you out this PowerPoint and some other documents just with the simple question. Well, basically it'll be section 13 of the manual and this PowerPoint with the 3 questions: what's working, what's not working, what's missing.
And will we include the service definitions
Yes.
as they are now?
As they are now.
Okay.
Because all we have so far is proposed things with regard to integrated supports. And I've sent that out to everybody, the integrated supports and the supported living definitions.
So we'll be also talking about the residential supports and the respite and the in-home skilled
Right.
personal care. Okay.
Yeah, all of those. So middle of December, you want to send me what's working, what's not, what's missing. Like, I know respite's missing for unlicensed AFLs. Let's see, and I will be safe in my community. This is our crisis services definition, and this definition isn't really understood, I don't think. It's a tiered approach. By tiered approach, it means you're supposed to start with one level, move to the next, move to the next if necessary. And primary crisis response is the first level response that it currently is an expectation of any provider of in-home skill building, residential supports, personal care, or in-home intensive supports. And the behavioral consultation is the next level where you're bringing in specialists to help develop a behavior plan if necessary, or to make modifications to the existing. And then out-of-home crisis is the facility step where a person goes and stays respite somewhere else, usually NC START. And this definition needs quite a bit of work. And that was very evident at the stakeholders meeting. There was a number of folks that commented on challenges with this. Like right now you have NC START, which can't do a behavioral consultation because of the requirements, which it doesn't make sense. Because NC START coordinators have to be trained through a very specific program, but they can't deal behavioral consultation. So those are pieces that we already know exist that need to be fixed in this definition. So I'd encourage folks to consider those ideas. Choose how I spend my day. Day supports. This captures adult day health and developmental day. It's facility-based, and it's oriented around pre-vocational skills. Yes.
Are all I know that choose where I live category needs feedback by 12/19. What about these other categories? I'll be safe in my community, choose how I spend my day. Is all that feedback due by 12/19?
I think all 3 of these categories are due by 12/19.
Thank you.
Yeah, I'll have to look at my notes to be sure. Because there was 2 groups that was put together. But that will be in the detail of the email that I sent. So everyone can read this on Thanksgiving. Supported employment. This is a best practice that we have to try to increase in the area. Some of the feedback at the stakeholders meeting was, the fact that it doesn't, the way our definition is currently, it doesn't really allow for clear long-term maintenance, which is something you need in innovations, because once you move to innovations toward employment, that's where you should, if you're looking at maintenance. Choosing what I do in the community guide. The state stakeholders group has looked very in depth at this definition, so we didn't touch on it a lot. They're still taking feedback for it. The service is not utilized as it was intended. It could do a lot more. Some of the feedback that's been heard, in community guide, there's a list of activities that a community guide can do. And a number of folks have argued that that's too restrictive, that list. That it should include more things.
It wasn't a list that you could only do, it was just a suggestion list, right?
Exactly, but some folks view lists are interpreted differently. Sometimes this is all I can do, sometimes it's thought to be, just guidelines or suggestions.
Creative people or system people.
Mm-hmm.
And are there still?
Or your utilization management people.
Yeah.
There you go.
Aren't there still agencies that are approved for community guide?
There are, but there's not sufficient agencies for community guide.
The authorization
And so
process.
is that something that, because we end up doing it, that we can
So
approve to do?
that's something that, so you're suggesting the community guide could be, if it wasn't, like the provider of services could be theoretically authorized to provide community guide, is what you're suggesting.
Right.
So that's definitely feedback to include.
Okay.
The issue with community guide, a lot of it is one, getting authorizations from SMC, because they've never been clear about what's required, especially outside innovations. Huge problems. So, and then also what training, because in the beginning, there's about 40 hours of training. And I'll tell you now, I have no idea what training they would require for community guide. So it's never been.
Not a service definition, though.
No, it was something Smokey was creating. So it's never been, and that's why a lot of providers dropped out. There's no clear idea of how to get authorized, even when you have it black and white, and what the staffing requirements were. 12 hours, the person said, I think at one point was being said. I get it, but, so that's never come out, and so as long as that's there, it will not be utilized. The other thing, in my opinion, is if you're trying to do it, and that's the service you're doing, national accreditation is kind of nuts.
Mm-hmm.
It makes no sense as a service.
Okay.
What's the educational requirement for a community guide?
I suppose on.
Yes.
No, it can be done professional, but again, in the beginning, Smokey, now Western was different. Western was a little bit more easier in using it. Smokey was not. And even if you had persons in the planning in the past, if it wasn't in less than 2 years, then, which was the original training, I don't know whatever happened with it.
And so we need to definitely, that's feedback that can be taken to the state stakeholders group.
But it also needs to be done locally.
And then it needs to be considered locally about how to enhance community guide.
Well, I've seen people get it that shouldn't have it, and community guides doing nothing and getting paid for it.
Well, and that's what you want to prevent too. It's a fine balance for sure.
It is a needed service.
It's one of those things that needs to be more thoroughly developed, and probably you need specific, pretty targeted group of providers so that they can have the volume that's needed to do the service. Community networking. There's a myth throughout the system that the only thing that this captures is volunteer work, which it could be a lot more than that.
This means community networking.
Right. Yeah, exactly. Yeah, it sure could be.
they're telling you all you can do is volunteer or take a different class, what are you supposed to do as a provider?
Yeah. Again, it's, yeah, care coordinators are getting multiple information.
Okay. Well, and that's an education issue. And you know, in everyone's defense, if the system, we at one point had a service called the community component of home and community supports. That service was required to be volunteer activities and nothing else. And when we did the transfer from CAP to, or the transition from CAP to innovations, the community component of home and community supports automatically crosswalked into community networking. So there's that belief that community networking is the same as the community component of home and community supports. I just think that's so funny. But anyhow, so the community component of home and community.
I don't understand where that is.
There was also the whole thing in community networking about you couldn't do activities with other handicapped people.
It couldn't be a majority,
which,
it couldn't be a majority of them.
Yeah, you couldn't.
we were told we couldn't do activities with your peers. That was not okay.
Well,
It had to be non-disabled, disabled. It had to be all disabled.
Right, all people with the waiver.
yeah, the goal of the service is to integrate persons in circumstances where they normally would not be. So you can't use this as like day supports in the community. It has to be working towards some type of community inclusion.
Like we had a summer camp that was mostly for kids with disabilities. We couldn't use this service there because they were not
Like the
typical kids.
ideal a good way to use this would be a child that's enrolled in public schools that goes to daycare after public schools, and he needs support in that day setting, maybe the Y program or something after school. And perhaps there's 12 kids in this program and 3 of them have disabilities, and those 3 are all receiving community networking. That would work. So that's an idea of how to use it. It can be used for a person to attend meetings like this, or to attend meetings for activities that they're interested in. So maybe, right.
Now, you can go to the Y and go swimming, that's like community networking. But you can go to the Y and do a swim aerobics class, and I know some folks who do it, and there are other people that are disabled. And that's community networking, because you're in this class at the Y versus I'm just in this way.
Yeah, and the goal should include like a person meeting other people without disabilities, just a lot of things that it's changing our philosophy and the way we think about things. And it's really hard because, you know, the longer you live, the more set in your ways you become. I know this from my own experience. But at the same time, people my son's age don't think about disability the same way that I think about disability. Because my son started school in 2000. His entire life, the ADA has existed, the Americans with Disabilities Act. His entire life, he's been integrated with kids with disabilities in his school. He doesn't see it the same way we see it, because I was 6 years old when folks started getting integrated into some of the classes that I was taking. Actually, to be honest, I guess I was about 10 or 12, because IDEA passed when I was 6 years old. So, you know, it's just a change in philosophy that we're going to continue to see as time goes on, I think, because it's very similar to other civil rights movements.
And my son's been included in school, doesn't like being in a separate setting, and that's usually when we have an issue.
The whole thing is a real, actual life.
Yeah. Yeah, it's
The idea of separating people, I mean,
eliminating the segregation.
all three of my sons attended Haywood Vocational Opportunities for 20-plus years. My husband and I worked, and they had people that worked with them there. And at different times, within a few years, they all said, we're tired of this. My one son wanted to start a lawn mowing business. They all want to do different things, and you can't do that if you're just put in a building with everybody else like you. I like going different places and seeing different people that aren't like me. So they like that too. So, that's really, really important.
Yeah, okay. So, community network, I'm going to be mindful of time. Get us moving along. Managing my own services. Self-direction is a best practice in the field. It's clear that when people take responsibility for their own supports, they tend to use less services. They have more freedom. They have a greater satisfaction out of their services. Right now, within innovations, managing your own services is incredibly complex. It's almost like we took something and said, how hard can we make this? So that's some of the feedback that we've received is how hard can you make this? Make it a little bit more, simplify. So that's some of the feedback that we've received. And then accessing services to support growth. Natural supports education, services to teach the family, different strategies. I mean, this is very useful for persons with autism and learning to interact with their children if they have autism, just as an idea. This is there. There's not been any proposals around it. It's something that's been within waivers as long as I can remember, just under different names. Especially.
Jesse, to go back to manage my services, are you going to give us some kind of service definition, or do we go to the Innovations Manual and look under agency of choice and employer of record and all that? How do we give you feedback on that? What do we have to look at to say, this works, this doesn't work, and this is missing?
And that's a good point for the individuals that are on this board. They should have the manual to be able to know. Oh, it's online, yeah.
Well, my intention is to send this out to y'all with the packet of service definitions, the same way that it was sent out to the state stakeholders group.
Okay.
Identifying the ones you need to look at. For manage my services, individual goods and
Except
services.
what the manual says is not what the waiver
Person that's
says.
self-directing.
And if you ever appeal or you're audited, it's what the waiver says that matters. So be very careful.
Service that allows a person to self-direct. Because in the employer of record model, the person that is directing services is the actual employer. The financial services agency that provides the financial support service is the bill through. They bill Smokey and pay the staff for the employer of record.
When he gets ready for comment,
those
yes.
Details, we're being relocked in. Those details are outlined in that service definition to an extent. But we also have an employer of record manual, an agency with choice manual, and it's just way too complex and too much. So really what it needs to do is be simplified in some way, and I'll send you links to that information too.
Excellent.
And specialized consultative services, we've been working to enhance this in our network. There's feedback about how ABA needs, applied behavioral analysis needs to be added, the vendors for that. There's also this is a place that START could be added, because START can be accessed for crises, or if it's outside of a crisis, using START behavior for START coordinators to train regarding behavioral needs when the person's not in crisis, to help develop plans and planned respite and other things. And then assistive technology, supplies, home modifications, vehicle modifications. Feedback that was received at the group was eliminate the lists.
Right, because it should come exclusive.
Because the list become exclusive. Now, if you read, depending, and that does go to, I think, one of the differentiations. You tend to get very policy oriented and rigid about your view of it. On the care coordination side, you're not. So that group, I can't remember exactly the order that these will be in, but that's the PowerPoint that was presented to the statewide stakeholders. And the statewide stakeholders received a packet of definitions, which I'll send to you, and the dates that we need information by. And I'll get that out to you by close of business Wednesday. And mind you, that might maybe be kind of late, but.
Jesse?
Jesse, we have a comment on.
I have a comment about the service definitions that were sent to the stakeholder group in Raleigh. It was the definitions out of the guide, the technical guide, the manual, rather than the actual service definitions as written in the October 1st, 2013 NC Innovations waiver. And there are differences in what the waiver actually says versus what that June of 2012 technical guide manual says. So if you could include a link to where the actual waiver, and it's actually listed as technical amendment number 1 to the NC Innovations waiver on DMA's site, on the innovation site. There just is some.
When you pointed that out at the stakeholders committee, I knew exactly what you were talking about.
Thank you.
And I'll send you a link to the clinical policy with the page numbers referenced.
Yeah, because the clinical policy.
The clinical policy.
Yep.
And the most recent one. But when you made that comment, I knew what you were talking about. And they should have sent the clinical policy definitions.
That's much.
The documents that you used.
That's much closer to what the waiver says than the manual.
Right. And I will also include a link to the ones in the manual.
Yes.
Just because parts of the manual piece, folks still thinks policy when it's really just guidance.
Correct. Thank you.
Okay. So any other questions or feedback about that PowerPoint and the information I'll be sharing with you?
Hey, Jesse,
Yes.
send that link information and the detailed email that you're sending out.
Yes.
Thank you.
Yes. Robin enjoys making my to-do list. Okay. Any other thoughts or questions?
I guess that would be part of the feedback, is it sure would be nice to have a manual that was correct and not have to have a technical amendment to it so that you don't know which one you're following, which and where and when.
The document that matters is the actual waiver, that the guide. The waiver is what they actually have to follow.
That's government work.
Well, and right now, you have the actual waiver document, the clinical coverage policy, which is very close to the same, because the clinical coverage policy has to be approved by the physicians group in Raleigh, which makes it enforceable. The technical guide that we're operating off of is really, we're not relying on it too much anymore. It's the best way to say that. It's still guidance, but the guidance is from June 25th, 2012. The last waiver update was August 1, 2013. That's what date I think the policy, clinical policy is dated March 1 of 2014, which it mirrors the actual waiver document. So what we will be trying to use as guidance is that clinical policy. And that's what I'll be sending you. But I'll also include the technical guide, because there's some good information in the technical guide for ideas about pieces and guidance. This will, I don't know that we ever get the manuals to all match. It's, when I drove to Raleigh and back, and I listened to this book by Bill Bryson called A Walk in the Woods. And he was talking, it's about his attempt to walk the Appalachian Trail. And in that, he's talking about the distance of the Appalachian Trail, and no one really knowing how long it is, because it's in the same government brochure from the Park Service. It lists like 4 different distances for the Appalachian Trail, like 2,150 miles, 2,147 miles, up to. So he's just commenting, and that's just about the Appalachian Trail, so it's no wonder we have so much trouble.
There's always interpretation of the waivers when the actual feds have actually approved. And that's why when you go to appeal, you have to use that waiver document. That's what's giving us so much trouble with these.
And that's now why the clinical policy is so close to the waiver document. They're all basically the same thing.
As this is being rewritten and we're getting these new service definitions, is there going to be anything in the new waiver about levels of service, tiers of service, levels of needs? Because we went from one side, it's always been, in my opinion, a waiver other than the enhanced personal care and respite, which everybody jumped on the bandwagon for that one. Is there going to be specific services for levels of need instead of a definition that only meets a certain level of need?
Actually, that's a good segue into the next topic on the agenda, which is identified management. One thing that will be very different in this waiver we're writing is, that it has been previously, is that resource allocation will be used. The resource allocation model will be informed by the person's supports intensity scale score and other evaluation information, but primarily the supports intensity scale or SIS score. And currently, the Division of Medical Assistance is working with a contractor to develop this resource allocation model. They're averaging out SIS scores across the state and comparing that to the amount of money that's spent on persons that have certain SIS scores. So we will ultimately get this model where a person has a budget category. That budget category may be, say, from $40,000 to $50,000 that they're supposed to spend or allowed to spend on their needed services. Maybe it will be from 70 to 80, but there will be a number of categories. If it's similar to the support needs matrix that was used in the Cardinal area, there will be 7 budget categories. I don't know if it will be or not same, but it'll probably be close to that. And basically, the care coordinator, before they even go meet with the family and plan development, will know that the person has anywhere from, say, and I'm just using this number for convenience, 50 to 60,000 for their base budget services. And that's what the team would work off of.
But I mean, are there going to be definitions for level of services? Like one personal care does not fit all the consumables.
Well, and you see, and that's where this
this model of resource allocation will allow you to say, well, I'm going to use personal care, but my staff has to have all of these pieces met. And if that's the case, you can choose how much of your budget you want to use to ensure that your staff's reimbursed for what they're doing. So if your budget category is $80,000 and you want your staff to be providing primarily personal care based around all this training that's outlined, then you can say, well, we're going to pay them this amount of cost. So there'll be,
My self-direction or?
it'll be much, it's going to be closer to self-direction. It's a supports account, and they're not going to be so worried about the levels within the service definitions, because what we've been historically doing is using the service definitions to control costs.
Right.
In this model, we're going to be using, the cost is set, and then you put the person's services to meet their needs within that set cost.
That's the difference.
That's the difference. So it allows you to do more because you know you've got this amount to spend. How do you want to spend it? So someone may choose to get better staff to just use 40 hours of service possibly instead of 60 hours of service. Because a team and a family might say, well, I want 40 hours of service at this rate because I know the staff's going to show up. That's why it's going to be a huge shift in the way we think. And
I'll play devil's advocate. What if that consumer needs the 60 hours of service with the pay that the 40 is going to get?
Well,
that's where you move back into those decisions. That's when the natural supports has to decide what they want.
What if there are no natural supports?
Well, and part of that is, if that person actually needs all of that, then the system will reflect it, we hope, and so the budget will be high enough to do it. But
Right, the budget would be high enough to then do it, theoretically. Now, there's the possibility that that's not the case, and this model will allow for outliers. And outliers will be those who maybe have a greater level of need, but use less resources because of their natural support system. Or you may have those that have lesser need, but need more resources because they have no support system.
I did have a question about the CIS. Say there's an individual that as they're aging, they're declining in their abilities, how often can the CIS be relooked at to take that into account?
Typically, it's reviewed every 3 years. A new one's done. If there's major life changes or a significant change in the person's ability, another one can be requested. And we have some pretty thorough processes in place for that. But where I'm getting at, I guess, with this is utilization management will change significantly with the move to this new waiver.
for 2015?
For 2016. And there has been a presentation to the state stakeholders group about utilization management and how it will be different. And that presentation will be shared with this committee in January. Because Robin's on the committee working on that policy, and her and either Robin and Rachel or Robin and I are presenting those ideas. We changed the order from the state stakeholders group because the overview should come first, and it's one of those step backs. Utilization management, we will follow the policy. So,
will there be a way, when all this stuff started, every cardinal did it, and we knew, and people, if I remember right, people's budgets got cut. When CIS started here, there was a bunch of denial from NCO LME saying, oh no, CIS is not going to be used for budgeting. 2 years later,
it was
and in the very beginning, people still are confused by it. So will these CIS be renewed, redone, before the individual budget starts? So if there's a you know, families are better trained on it than they were 2 years ago, and we all knew what was coming, but they got denied. The mistake.
Well,
So how do we fix that if we get to?
I would, the way the SIS assessment's supposed to work is if a person's meeting and being honest, it gives you a reflection of the person's needs and how much support they require.
But there's a difference between people now using it and in the beginning people using it. And a lot of occasions, 3-hour meeting, there's all issues with it.
Well, but we have to do it every 3 years, so a lot of the folks that got it early on will probably be getting new ones.
I have some,
We even get to.
Jesse, I ran across some information recently in a peer review document that indicates that there is a SIS verification committee, and they actually invalidate SIS scores. The SIS verification committee looked at a SIS and determined that it was inaccurate, and that occurred 6 months after the SIS. The participant enrollee was not notified. In fact, until I saw that peer review document, I wasn't aware there was such a thing as a SIS verification committee. So there's a lot going on about the SIS that families are unaware of, and it sounds a lot like what PBH Cardinal did and why that lawsuit is still pending.
I just think there needs to be a lot of training and a lot of discussion before we get to 2016.
So really, what we need education regarding the SIS to this group and the processes at Smoky around the SIS.
One thing that happened with my son, the SIS examiner who did it realized that she was asked the questions, it wasn't being explained on how to answer them, and she redid my son's SIS, and they wouldn't let her enter because she had entered the wrong one, and she redid it, and this was her who did this, not us. I mean, she realized that it was incorrect, and so they wouldn't let her correct it into the system because she had already entered it. You know, talk to Renee Leland about that.
Wow.
Okay.
That's something too, that if there is an error, they need to be able, the SIS examiner ought to have the authority that she feels.
To change
if she feels like it, not necessarily the provider or the person, but if she feels like she should be able.
Well, I tell you.
Simple errors, because we had folks with the wrong age, like 20 years the wrong age. And, you know.
They can't correct that.
They can't correct it.
Okay, so those are things that we definitely, I can't speak to the SIS more than just big picture pieces.
Oh, gosh.
So I do think that probably following the utilization management presentation, that we should definitely look at having the SIS included in one of these meetings. I'll take that back to the Innovations Committee, and we would want to include persons like Robin and Allison Farrington, the manager of the SIS team, so that they can present these details. Because really my piece is the big I just can't get into the weeds of the SIS. But it's definitely something we all should know more about, and a topic we should consider in this group. So,
yeah. This is Ronnie and Boone. If you're going to have a presentation on the SIS, my wife and Margaret and I probably want to be at that or be involved in providing some information on the SIS.
okay. All right. Maybe we'll coordinate that to where it's a Monday night that I do not have to come.
Can I put that as an action item on you?
Actually,
Not my action item.
well, we just need to take it back to the Innovations Committee and coordinate with Alice when she can come. And then, outline exactly the best way to present the information around it. Let's see. Moving on to, I need to plug back in. Any other comments about utilization management and touching on the CIS that I can decline to answer?
Is the top dollar still going to be the same thing as ICS?
Well, an education on that piece. Currently, the innovations waiver is set up to where we can utilize up to 115% of the average state cost in a community-based intermediate care facility for individuals with intellectual disabilities. Our waiver cap right now is $135,000 per person. That's how much we can spend in waiver services for an individual. Our per member per month, we receive the average amount, which is around $60,000. So anytime a person's receiving in excess of $60,000 worth of services, they are really taking money from someone else's PMP. So if a person's getting $30,000, we're using part of their money for someone else. So it's a little bit of a shell game, so to speak. Every time a waiver is rewritten, it seems the waiver maximum changes because it's always tied to community-based ICFs and institutional rates. When I first started doing utilization management, the amount was $45,000. James started it when it was less than that.
That was 5674 when I came in.
5674 is what it used to
They've
be.
never budgeted, since I've been here in 95 and I worked in West Virginia, no states budgeted 100% of the max. And the problem was when I came in 95, we're not able to do, but somebody pushed things to utilize the max, which unfortunately I think set us up to do that. So it's never been the full amount. So, and I think that's the problem, is people think that's that full amount.
But, so, that number's there. I suspect that number may change. I don't know. It hasn't gone up since 2005.
What happens when they cut their rates with ICF and Mars?
Well, that's a whole different thing. So maybe we'll lower the 135. I don't know. But there will be a cost limit because waivers are required to show some form of cost neutrality. So there will be the actual maximum waiver limit, and then persons will have budget categories that have limits within. So you'll really have a waiver with several tiers inside it because of the resource allocation. Now those tiers within the resource allocation can be exceeded and have more flexibility than the top cost limit. And then there's actually some debate around whether or not we should even have a cost limit. But it's required by law. So there will be one. It's just what will that number be?
And who's going to determine that?
It'll be based on the ICF rates.
It could be legislative, they tell them what they'll do.
Yeah, and well, there's always the possibility that there will be there's talk about another supports like waivers.
Yeah, prior to 2005, it wasn't at the ICF rate, it was low.
So, moving on to our last agenda item. Last month we talked about relative as direct support employee and the communication to clarify some of the roles around this. And This is still in draft form. For some reason, draft's not showing up like it should. And everyone should have a copy of it in their packet. Some of the comments that were brought up, was the question about what's the best practice? And the language that we've added to that to address that concern is, this is not considered a best practice because the intention of the waiver is to enhance and supplement natural support systems instead of replacing such systems. So that's the response to that one part. So feedback impacted that. Feedback impacted another part down near the end of the document. And there was a lot of concern voiced about the fact that we was doing every other 90 days. And in this communication, trying to find the right spot. We're trying what increased monitoring is, and that's one care coordinator visit. I'm going to be a contact for questions about this. And here's the part that really changed. The previous one that we looked at last month had us looking at doing 90-day approvals if we didn't feel like there was justification. So basically what we'll do now is we're either going to say yes or no with the annual plan. So if a person requests 90, or say that the provider requests for the guardian to provide 60 hours a week, we're going to review that request. We would basically receive a Part B and a form which is showing 40 hours. Then we would receive a Part C, which is showing the additional 20 hours. Well, the network development CF team is going to review it, and they're either going to approve the Part C for the duration of the plan year, or they're going to deny it and give a 90-day transitional period. After the 90-day transitional period, there will not be another review, because it's really the question, is there justification or is there not justification? And if there's justification at the start of the person's plan, the provider does not need to be burdened with submitting a request for justification every 90 days. So that was one thing that feedback here has impacted.
So if you ask for 60, is there a chance they'll say yes to 40 and no to 20? Or is it no to 60?
No, it's a request for 60 would be two different reviews. Because a request for 60, you're either going to have a Part A or Part B. For the Part A form would be for a new staff, but let's just say this is an existing staff that's been providing 60 hours. The Part B form would be for 40 hours. The Part C form would be for 20 hours. So let's say that there's also a respite worker that's working with this person. And that respite worker, the provider says, is available for more hours. Well, we're not going to approve the Part C. We would approve the Part B, but probably not the Part C. Because, the reason that we're supposed to be approving family members to provide services is because there are no other providers that can provide the service. So if a person's receiving other services, it suggests that there's a provider or there's someone there to provide the service. And we've actually had providers tell us that they can provide staff. So we're putting the provider in a bad spot if they're saying, well, I have staff. And we're saying, well, you got 90 more days. You got 9 more days. And, some feedback from this group was that, well, we're going above and beyond the policy that's in the waiver document.
No, you're not.
And clinical policy by
No, you're not.
these extra steps all the time. So we're supposed to check for justification. If the justification's there, we'll approve it for a year. If it's not, we're going to say, no, you got 90 days to step this person out
Can you go to page 3 up towards the top, because this is, I think, something that as the providers are going to want to pay attention to. Okay, so you go down 3 lines. Even if approved, provider agencies are expected to continuously be looking for a non-related staff to replace. So what that says to me is that any provider who is currently employing relatives is going to look at that and say, no more, because it will cost me. I will be forever interviewing staff, even though the approval for the family member is for a year, unless my reading is off.
This is the word continuously.
Continuously looking for a So no provider can do that. That's a full-time job right there. If you said,
they don't do it with your short staff.
So they're saying Jane, they're saying that Jane will be with little Johnny for a year, but I, as her provider agency, must still be looking continually, and the paperwork is a nuisance.
But that's for in excess of 40 hours.
That's for an excess of 40 hours. And you see, we have been previously asking the person to submit the forms every 90 days.
I think just the word continuously is the problem, because it implies they can't really stop. If they've been authorized for a year, you're gonna stop.
I have to keep reading, because then you get down there, it does say if services. So if services are approved at 40 or less, you don't have to. It's the additional hours beyond 40 that make the requirement that you continuously look.
Well, if they got approved for a year, why would you keep looking?
Right.
Unless the family is requesting that they really don't want to do above that 40 hours.
Even if they said to continue to look, isn't the same as continuously looking.
Right.
So you've given approval for excess of 40 hours for the entire year, and so as a provider will no longer be hiring any relatives because it's way too much work for me to do A, B, and C anyway, let alone to do the grievance for A, B, or C. Now I have to be looking forever for this staff person, for somebody that's been approved for a year.
And that's the thing, as a parent, to me, I feel obligated to give natural support and to do all I can outside of that realm. So to me, the policy should just have a set number of hours and that be that. And then if I die or something, whoever comes in after me is not related, it doesn't, that's, as a parent, that's always my biggest concern, what happens when I'm gone. So I'm gonna do everything I can while I'm here, so maybe the policy should just say, hey, 40 hours, anything over that, if you don't want an outsider, then do it as natural support. That would take the burden off the providers. I mean, I'm a parent.
Excuse me.
This is a parent.
I would like to speak as a parent. As a parent, this is Mary Short in Lenore. As a parent, I have had experience where staff abuses the individual, and now suddenly I had to quit a job to rescue her. So I don't trust unrelated staff, ever. We have failed unrelated staff. The ISP document contains all of the documentation of the failure and the failure and the failure. The ISP document contains the fact that the team met and discussed the options for other available staff, and the team decided that employing relative as staff is what was best. This policy does not follow what the waiver document policy states. The waiver document, Appendix C-2, little letter E, is very clear that if the ISP contains documentation that the individual was given an opportunity, then the individual gets to be respected and their right to have a relative provide services needs to be honored.
How do you separate relative and natural support?
Natural supports, the federal law describes natural supports as voluntary. As a natural support, it has been my experience, like I said, I had to rescue. So I can't work another job if staff doesn't show up. I apparently can't be approved as backup staff. So apparently Katie and I need to boogie on down to the homeless shelter and then hope that this unrelated staff is going to show up to perform her services down at the homeless shelter. You don't understand if someone is on the severe and profound end of this and they have no ability to communicate and to tell, you do not understand. And this policy does nothing more than force Katie to either live with her natural support at the homeless shelter or be moved to a segregated site of a group home or an institution. This policy is not in keeping with what the waiver document says.
I agree with this. Here, 40-hour work week is what most people work. In a sense, then say, I think that
AFLs work more than 40 hours.
They're not parents.
AFL is not, they're not hourly employed.
No.
They have a.
They're not hourly, that's true.
Why do you want Katie to live someone other than her family home in the most integrated setting? Why, if there's no staff, where is it you think she's going to live?
Well, that's not what I want. I don't know if you're speaking to me or to the group, but as a parent, that's certainly not what I would want.
Well,
But that's what you've just told me, 40 hours is a regular work week.
that's, let's back up for just a second. We don't want this to get personal or client specific or person specific.
Why don't you all put your thinking caps on?
We're required by the waiver to have a prior approval process. That's also there. The justification piece that we are expected to look for is why there's not other staff involved.
The waiver document talks about the ISP.
I'm trying to get to the family preference isn't supposed to be a reason. Complex medical needs, history of difficult interactions, difficulty with communication, past use of relative legal guardian. That's not the parts that we're supposed to use for justification. What we're supposed to use for justification is the inability to find staff that can do this for the person at a comparable pay rate. And we, in looking at this policy, or this statement really, we're going to accept justification as to why no other direct support employees are available. That's what we have to have. The over 40 hours, it's a good point. The continuously looking for non-related staff, it's doubtful that a provider would do that. But there's still the expectation that what's going to happen if something happens to the natural support system. You have circumstances where no one's able to provide respite. And in those circumstances, there should be continuous efforts to find a staff member. You have circumstances where folks do not even try to access respite. It's one of those pieces we have to do based on the policy. We've simplified it to where we're either going to do a full year's approval or deny it, one of the two, instead of the constant paperwork burden we're placing on everybody. Yes?
Hey, this is Rutherford Boone. Come in when I get a chance.
Yes, Roger, go ahead.
Go ahead. Just reading this letter, I'm thinking that the first page gives a negative overtone to the use of relative as provider. Kind of assumes that, and this might be the case with some, but it's kind of assumed that parents are abusing the system.
Right.
I think it needs to start off with the values of relative as provider as a last resort to institutional type placement. And I think if we focus or start off with the value of the relative as provider, and it is a last I can't remember my words now. Last resort as opposed to a first resort. But there is value in the relative as provider that I think needs to be captured in this letter somehow. And I got a feeling with how this has started as far as the accusations that parents are kind of using the system is what's rubbing people the wrong way. So.
And I agree with that. I was thinking the same thing when I first read this. No one's making a killing doing this work. No one.
Who said I agree with that? I didn't recognize that voice.
Tracy from Watauga Opportunity.
Okay.
Jesse.
Jesse here at
Yes.
Silver have some comments on the same topic. And somebody will ask a question when you're finished. Do you want to?
I heard Michael start to say.
Yeah, I just want to make that point that there is value in the relative provider when used correctly, and I think that's not being captured in this letter. And I think the focus should start off on the value and then go into the what do we need to fine tune.
Hey, Jesse.
Yes, Michael.
Why don't we provide the plan and put it in sequence and just make sure that we can get to as many as people as much as we can. But this is you have my suggestion.
Okay, thanks, Michael. Anything else in Boone before we move to Silva? Okay. Let's go to Silva then.
Okay, this is Becky Garland. I'm a parent, and I agree with the wording is almost like a punitive thing, and a lot of it is a resources issue. Just to give you, for instance, my son came home from his post-secondary ed setting in May of 13, and we've really been trying to get at least no less than 3 staff. We live in a very rural area, and we've been trying to get no less than 3 staff now for over a year and a half. And we have succeeded in getting 2 staff that are non-family members, but we've had to continue to rely on a family member to I call it back cleanup. And I guess my question is, we advertised in every local newspaper in a 3-county area and got 0 response. And so, my question is what happens if you do everything in your power? What is going to be the fallback plan? If you can't get anybody but that family member and then you run out of that time period, how is that going to be addressed? Because I don't think it's so much, in my case, we don't want to use family staff unless we have to. But it's just the reality of the lack of resources. And I have my Q sitting here, she can attest to that. We have tried to get that 3rd and 4th person and can't accomplish that.
At least you're not asking for over 40 then, I doubt.
That's, I guess, some clarity, too, is that everything you described, a rural setting, unable to find staff, are reasons that we would approve.
Liar.
That's the justification we're expected to look for.
Liar.
This also just applies to relatives or family members that live in the same home. as a participant.
Well, they were.
So that if you're,
Yeah, they
yeah.
were. But I guess what I'm trying to say is if
Answer
you
the
guys
question.
box it in, so if you put these bright lines around this stuff, you're gonna have nothing but trouble because every dynamic is gonna be different. And I realize that there has to be guidance and there has to be policy, but you start creating these bright line rules on implementation and it's gonna be really tough to not to run into safety issues like this other mom was talking about with abuse and other things because you're just trying to get staff that's not family and you're picking from a very slim pool of people who are trustworthy and who are appropriate, are trained. And then you run into, them nobody in their right mind honestly wants to go to work doing the rest of it for 8 bucks an hour. Amen. They can't do it. They can't afford it. And so you can't get very well qualified people. Mm-hmm. And I think that's another area, and I'm going into a whole new realm that needs to be visited in this waiver of how the costs are allocated amongst the services. Because I have somebody coming in and basically monitoring employment, and they're getting paid like $18 an hour, and then I have somebody who's in the personal care, hardly getting more than $8 or $8.50, and to me it's backwards. But I'm getting in a whole new realm there, and I apologize.
Yeah, you're getting into a whole new realm, but I understand that realm. So let's step back to this relative as direct service employee.
Can you, Jesse, this is Walter, can you still take feedback on this?
It still has draft across it, even though it's not showing up. And this is really just a communication piece. What I've heard, the things that I know that I can change on this document are the pieces that Rogers shared. It could definitely be written in a more positive tone from the start.
It would help.
The continuously looking piece, what was that?
It would help if you didn't bold and underline stuff, because that's pretty much yelling at us parents. See, I don't do direct services for my son because I know it was an old can of worms mess. But in this document, I can understand why parents find it so offensive. And I can see that in just the wording. But it really, it's offensive when I see somebody bold and he's yelling and underlining certain things. Because what that does is pretty much, it's kind of like I know you're making a point and you're kind of making that stand out, but it's also yelling at the person that's reading it. And that kind of comes across and rubs people wrong. I also understand the problem is somebody who's actually provided Q work and trying to hire staff members and families. It's in some cases that's all that you can find, and it shouldn't be something that's short term. If it's justified in the person-centered plan, like she was talking about, the advertising, looking, the abuse, and neglect. If that stuff's in the person-centered planning, there should be no question of justification for approval. But see that I see the different levels and the different categories and so forth as really being barriers to really promote that positive attitude.
And I think I'm going to jump off of what Walter's saying. This is Becky again. I think the wording, if it's worded appropriately, it can be used as a guide for the care coordinator and the Q to help walk parents through the process of going to the last resort. And, because honestly, I want my family not to have to be involved.
Right.
In this process, but I think that as Walter's saying, the punitive approach to it is making it look like we're taking advantage, whereas it could be a working document, a living document that helps those parents or those guardians to figure out what's the next step. And with this as the last resort.
Well, Well, let's hope she never has to rescue her kid,
Okay.
right?
That's a lot of feedback.
Walk in my shoes.
And, boy,
It's a very touchy issue, because
it's a very touchy issue. And,
you're not
you know,
on
every time,
5 o'clock in the morning to take care of my son. I mean, I know that. And yes, it's my son, but the state has opened the door for that. And I think the state is trying to see what the MCOs will do before they'll jump out and make a decision on it. And that's kind of scary too, because we don't know what the state will do once they decide.
Jesse, in all of this, when Dave Richards was going around and he was talking to stakeholders and everyone, one of the topics that kept coming up was the inadequate and inappropriate staffing that was available. That was a topic across the state. What is the state doing to address that? If they're having all these meetings about service definitions and relatives as providers and everything that is being looked at, if there aren't appropriate, adequate providers, what is the state doing if that was one of the main items that was identified? We're moving forward with a waiver, with new service definitions, and providers as direct care staff, and everything else. But the main item that was found was inappropriate, lack of staffing. What is the state or the MCO doing, whoever's responsibility it is, to change that main item that's needed for this entire program?
I have a suggestion. Take away the money that the MCO spends doing these forms A, B, and C supervising parents and pay for decent staffing. Because it's a value call. We can't value call whether Mary's doing the right thing or whether I'm doing the right thing or whether you're doing the right thing. You're the parent. You get to make that call. And if I don't agree with it, I keep my mouth shut. So I'm saying take the money that we're spending telling relatives they can't work and throw it back into the kitty so we can hire staff.
And I understand that, but I guess my question that I'd like answered on any level, whether it be the state, the MCO, or whoever, if this is the main topic that was brought up, what is the state doing while we try to write a new waiver, while we try to come up with service definitions?
There is no answer, Jenny. There is no money. The bottom line is there's no money. They're giving us tiered systems.
I'd like to add the final word. The final word I have to say on this is that when we had home supports, which was the only service definition that parents could provide, in the entire state of the 12,000 individuals on this waiver, children and adults, there were 1,091 parents doing home supports. Of that 1,091 number, 40 were doing home supports level 5, which was for 12 and a half to 17 and a half hours of direct contact. Level 4, there were 450. So there were potentially only 500 families in the whole state who were doing more than 40 hours. And this ridiculousness of approval and non-approval, and it's just beyond my comprehension. 500 individual out of 12,000? Somebody put a thinking cap on. Thank you.
okay, I think that's a good last word.
For any action items for you, have you created any action items for you?
And I did want to say something about the provider takes the case because the provider knows their staff. The provider wouldn't want to do trying to find 84-hour staff or 112-hour staff.
I need to take back some of it. We'll take this back once more.
And, that's really the only thing I can do. We did receive quite a bit of feedback, and believe me, I'm hearing everything about this. It's just one of those things
You don't make the decisions, and that needs to be said, we understand that.
But, we'll take it back because it's amazing what you learn each time. And, I appreciate everyone being willing to share. And, I see every side of this, I really do. And every time we talk about it, I see a different side. How many sides can it have? Maybe it's just a circle. Right, maybe it's just a circle, they all blend together. But anyway, I do appreciate everyone coming out here for Monday before Thanksgiving. We will not be meeting again until January. I'll include the date with the email that goes out. It will be the fourth Monday of January, so the Monday after Martin Luther King Jr. holiday. We'll get our notes out hopefully very soon. And it's always a lively discussion. One thing I know for sure is I'm going to be really tired the fourth Monday of every month. So I do appreciate everyone coming. Thanks.
Thanks.